Thank you. I'm going to be talking about secondary IOL implantation in challenging cases. But before we do that, I think there are certain indications where we would do a secondary implantation when you have a PCR, zonular dialysis. I don't need to explain this, but you can take this as a snapshot if you want some indications of where we use secondary IOLs. I also want to showcase that the procedure I'll be talking a little bit more about will be the glued intraocular lens, and hence certain instruments that you probably need to or want to have inside the OR. The need to definitely have is a three-piece lens and forceps, the glued IOL forceps. Everything else is a good to have scenario over here. The marker is something that we devised with Epsilon. I have no financial interest with them way back in 2014-15. And the Trocar AC maintainer was made by Mastel. I have no financial interest with them either. Um, I want to talk about a little bit of a plan A. So I love the bag. I like to keep the bag. And I know that comes as an irony that I'm saying this uh, since most of my talks are always given on glued intraocular lens. But the way that I like to keep the bag is something called as the paperclip hook or the glue dial hook, which basically is a device that is made with PMMA. And here is a case of a subluxation where I've made a flap or a partial thickness flap with a sclerotomy on one side. The distal end of this hook is basically taken out through that sclerotomy or externalized, and the proximal end is inserted into the anterior capsular rim. But before that, I'm placing some capsular hooks in place just so that we can actually stabilize the bag while I'm doing my phaco in this procedure one, and cut the excess distal part of that hook and tuck it in. So that's permanently placed now. I don't have to change it. This basically gives me a full-fledged bag support for intraoperative phacoemulsification, after which I do place my CTR or a capsule tension ring. I like to delay the capsule tension ring to the end or late to the last moment that I have to put it in. In this case, that was at this point of time, just before the cortical removal. Once it's removed, I remove all the capsular hooks, but I leave back that paper clip hook in place. And this device was coined by Dr. Susan. I want to congratulate her for this device. It's exceptional, it's beautiful, and it stays permanently inside the eye, as you can see. And just with the application of glue, I would like to, this is some of the post-operative pictures of day one of the same patient with the hook. You can see the hook is holding the bag in place with the CTR also, and a centered IOL. If you see, the hook kind of goes into the sclera over here, and you can see this on the UBM. But nonetheless, I have to also say that sometimes, even though you tend to do the best for the patient, sometimes what happens is this. I'm doing my normal case, which looks pretty okay. Just a little bit of subluxation over there. It was not even as bad as the previous case, honestly speaking. I mean, what you can see when I'm doing my Rex is that it's starting to move a little bit, and I'm not happy about that. But so I've completed my Rexes here, and I've placed a capsular hook. Now I'm going to be placing a capsular hook in place here, just because I want to be safe than sorry. I've placed my capsular hook inside the bag and want to make sure that there is no movement while I'm doing my phacoemulsification. That's a small trick. Nowadays, I've started to put 4 hooks, but earlier it was 1 hook was enough in this small scenario. I did my complete phacoemulsification in this case, and once you go along with the case, you try to understand that you try to get a little bit bolder, and I did get a little bit too bold, and see what happens. Oh, that's not meant to happen. And watch it again. I went for the cortex, which I shouldn't have done, and that too in an area where I know there is a little bit of subluxation. So these are scenarios that I'm not worried to show this, because this happens to all surgeons regardless of caliber at times. And so the first thing I do in these cases is I suture up that wound. I make sure I put a trocar, either anterior or posterior trocar. Once I've made put my trocar in place, I make sure that I use my glue dial marker to make my flaps, because I know that there is not enough capsule support now. I've made my flaps, leave the cortex, leave the bag exactly the way it is. Just make my 2x2 millimeter scleral flaps, partial thickness. Once I've made my partial thickness flaps, I'm making my sclerotomies under the flaps, about 0.75 to a millimeter behind. Direction should be towards the center of the globe, not the center of the pupil. Otherwise, you're going to be pulling iris. Now I've made my corneal wounds, so basically making my side port entry. And now using a vitrectomy cutter and the infusion turned on, I am admixing vitreous, cortex and bag remnants along with that. So I'm cutting away and aspirating all of this, either cutting or aspirating between all three, basically completing my anterior vitrectomy and cortical removal in this with this step. You can use the sclerotomies that you've made. You can use the limbal route. Either which way you want. You must ensure that you clear up that space of any vitreous. That's the most important point I would like to say. Externalizing the haptic, very important. Hold the tip of the leading haptic and externalize it. Now using the handshake technique, and I will come to this handshake technique as a separate point later on because it's a very important step in this procedure. Watch it again. Once the leading haptic is outside, I'm basically taking and placing my trailing haptic in a particular position. Once that's done, I'm internalizing my trailing haptic, grabbing it with my left hand. Left hand, right hand goes through the sclerotomy and hold the tip. This is very important to hold the tip of that haptic and bring it out. Otherwise, that flange is going to break. And that's something that we don't want to do. So once this is done, you have both your haptics externalized. Now you make your Gebel-Chariot's tunnel. And once you've made your Gebel-Chariot's tunnel, you can actually just tuck these haptics into that tunnel. Some people have used diamond blades. Some people have used different kinds of blades. Some people even use the crescent knife to kind of leave that haptic in place. I like to use the 26 gauge or the 27 gauge needle, whichever you get. And once you've placed this into the Gebel-Chariot's tunnel, you basically tucked your haptics right in place. Closing up is pretty simple. You use pilocarpine or you remove your trocars first, put some glue in place under the flap and the conjunctiva to close up this wound. That's pretty much how we like to close up this wound. Of course, you have to do some stromal hydration as well. This is what I wanted to say about the glued intraocular lens procedure, and this is how the post-operative day 3 looks of the same patient. In summary, if you want a snapshot, this is what we do in terms of steps, but I'll go to how do you master this? How do you become better at this? First things first, you can use an anterior infusion also, and that is done by the trocar AC maintainer. If you have flaps, do not make your flaps too large because then you do not have enough haptic to tuck. So don't make them 3 millimeters or 5 millimeters like how you would do in a trabeculectomy flap. This is a 2 by 2 millimeters that works perfectly well for these glued intraocular lens procedures. If you do have your white to white as 12 millimeters, please move over to a vertical glued intraocular lens that works best. Next one is the direction of the needle, the sclerotomy under the flaps. Watch this, guys, very important. The direction of the needle should be towards the center of the globe. Otherwise, what you're going to have is, look at the left one, you're going to have some amount of bleeding like this, and that could abort your procedure itself. And this is a step which is very important. So direction of the needle, don't drag the iris, go behind the iris. That's the idea. And circumferentially make that tract circumferential to the limbus, because that goes along this memory of the lens. That's something that you need to know. Pilocarpine can be used at the end of this case, but make sure that you wash off any pilocarpine at the end of it. If pilocarpine does not close this pupil, and sometimes it does happen that you have an optic or an iris capture like this, if this happens on table, be rest assured it's going to happen post-operatively, and that point of time you won't have anything to do. So what I've started to do in these cases is to do a single pass fourth row or a pupilloplasty of your choice, because that prevents this scenario from happening. Some very special scenarios where you have a 3-piece lens or a single piece, old PMMA single piece lens, which is really good actually, it's just dislocated. You can actually, just making 2 paracentesis wounds, you can refix that same intraocular lens using the glued intraocular lens procedure. The other one I wanted to talk about is the glued IOL scaffold. Basically, it's a very, very transparent lens here, which is subluxated. So I've just put it into the anterior chamber, pilocarpine, bring the pupil down, do my glued IOL behind this lens. And because it's so soft and this nucleus is so soft and young, I'm able to emulsify this using a phacoprobe at power of 5. So this is the post-op day 1. I'm sorry about the blurred image, but that's just because the camera, not the cornea. Cornea is crystal clear. Um, Glued in intraocular lens with endothelial keratoplasty. I'm basically laying a foundation with doing the glued IOL and the pupilplasty. Once the foundation is laid, I can actually place this graft and that air bubble will now not go down. So these are some of the advantages of doing the glued intraocular lens procedure in these cases. I also wanted to show this is the post-op of the step 1 was 1 month after just glued IOL and then the 4 month after the endothelial keratoplasty. Thank you very much. I wanted to showcase this procedure to all of you, and I would love to have thoughts on this as well. And I will introduce our next speaker after that.